Hello and welcome to Dragon Bytes, the paediatric podcast aimed at anyone interested in child health. Happy New Year. And today we're joined by Dr Graham Shortland and Assim Javaid, and they are going to talk about metabolic illness and the sick child.
Hi there, my name's Assim. I'm one of the presenters for Dragon Bytes, and I've been joined yet again by the absolutely fantastic Dr. Graham Shortland. Hello, Dr. Shortland.
Good afternoon, thank you very much, Assim.
So you were kind enough a few weeks ago to do a podcast with us about newborn screening, and you kindly agreed again to discuss further inherited metabolic conditions with us today. So I think the topic we decided for today would be about investigating presentations of acute illness in children.
Yeah, that's right, and I suppose it would be natural to start in the neonatal age group, in which a significant number of patients with inherited metabolic disease, IMD, do present.
Yeah, so that sounds like a good starting point. So should we kick off there? So how do children typically present, or neonates typically present with inherited?
I think like all parts of medicine, as well as the presentation, it's really important to still think about a good history. So particularly in the neonatal period, I think there may be a family history of illness. It may be very simple. It may be that the family are presenting and that they've had another child with a similar disorder. And don't forget that although we talked about newborn screening previously, that a child with MCAD, medium chain acyl-CoA dehydrogenase deficiency, a child with maple syrup urine disease or isovaleric acidemia can present before the results of the screening test are available. And it would be important to ask about the family history because, as we know, these conditions are autosomal recessive, so there's a 1 in 4 chance of presentation. If there's no history previously of the condition, then it is important to ask about consanguinity. There is an increased risk of an autosomal recessive condition, and all of us are walking around with between 1 to 8 autosomal recessive mutations. And we know that in a consanguineous population, there's probably a greater chance of having an affected child. So I think that's very relevant. In the pregnancy, there might be some clues, and certainly the presentation in the mother of HELP syndrome, hemolysis, elevated liver enzymes and low platelets. We have seen a number of patients with the long-chain fatty acid oxidation defects presenting after a mother has had HELP. Generally, we don't automatically screen every child who is born of a mother with HELP, because there are a large number of children who are completely normal. If, however, a child should present with being floppy or hypoglycemic or signs of a mother with HELP, then clearly we would suggest screening with urine organic acids, acylcarnitines, for a long-chain fatty acid oxidation defect. Maternal PKU, a child may present with seizures, small head, may present with cardiac problems. We would hope that we know about all mothers with maternal PKU because we've been screening for that for some time. And I suppose the other thing is in terms of previous miscarriages, has the mother lost children, or has there been a history in the family of perhaps babies dying with sepsis or babies dying of an unknown cause? And clearly that may have been an undiagnosed inherited metabolic disease. The one that obviously springs to mind is the presence of E. coli sepsis in a baby with galactosemia. Was it that the baby died of the E. coli sepsis before the galactosemia was actually diagnosed? So be aware of the history of not necessarily IMD, but perhaps a history of sepsis in that family. So that it is really important to actually look at the history.
It's interesting the number of things you've raised there which could actually have an influence on inherited metabolic disorders just from the history alone. But you've also mentioned a few things that we might be able to pick up from clinical examination.
Yeah. Yes, you're right. And first of all, the presentation of IMD is going to be sometimes, in a lot of cases, non-specific. And the child may be unwell, they may be lethargic, feeding problems with some vomiting, abnormal breathing, perhaps suggesting a metabolic acidosis, hypertonia, and possibly seizures. Characteristically, if you've got an intermediary metabolism problem of glucose, protein, or fat metabolism, you usually see an asymptomatic interval in the child. So the placenta, if you like, the placenta has been doing the job of filtering abnormal metabolites, and the baby may initially present in the first 24 hours as being well, and it is only when there is an introduction of feeds, an introduction of or perhaps a period of starvation when they are being clinically stressed, metabolically stressed, that then unmasks the metabolic condition. As you say, there are some specifics, and I think one would look for certainly galactosemia. One would look for evidence of liver disease that may be apparent, a metabolic acidosis on a routine blood gas, a hypertonic infant particularly, or the presence of seizures. So as well as the non-specific presentation, there is clearly a few things that might point you towards it. It's really important to emphasize again, as I'm sure all the trainees and those listening to this would recognize, you have to work alongside making sure that you have ruled out sepsis, that you have ruled out a number of different causes whilst you are considering IND. I suppose the other thing is the neonate who has a period of being well, you introduce the feeds, becomes unwell, you stop the feeds for the septic screen, child gets better, and you say, oh great, that's fine, and then when you introduce the feeds again, the child gets worse. So it is again looking for a pattern in the neonate.
Oh, that's really interesting. Yeah, the non-specificity of it all can be really difficult, particularly in the neonatal period, can't it? Are there any differences then between how neonates present compared to, say, older children?
Again, older children can be difficult. I mean, look at the same factors in the history. Look at the fact, is there a family history? Because don't forget, some of these children may go home and then present back to the paediatric intensive care unit. Look at neurological signs, which can be focal or which can be general. You might, if they're coming back later or later on in the illness, they might be presenting specifically with, again, liver dysfunction. The other one is a group of infants with cardiomyopathy who may present with initially heart failure or defined cardiomyopathy, which has an underlying metabolic cause. So there might be some more specific features to systems, particularly such as the liver, the heart, and perhaps encephalopathy. The child that is repeatedly admitted, so you might see a child with diarrhea and vomiting who gets admitted, who gets better and gets well and goes home and then gets readmitted 3 or 4 weeks later. So it's actually just again thinking, why is this child having a number of admissions, and should we look further in terms of that pattern of illness for an underlying IND?
Okay, that's really interesting. And yet again, it brings up questions about, you know, the difficulty in picking these kids up, the fact that we actually sometimes have to wait for several presentations before we might even consider IND.
Yeah, and I think that's right. I mean, I think it's about having a level of suspicion, and I think it's about looking for other factors, as we've highlighted in the history, having a high level of suspicion, and actually deciding that this child is slightly different. This is the third time that it's been in presenting like this. There was a family history of an early loss, and we never found the cause for it. So again, it is in fact, you know, it's what good clinical medicine is about. It's about being astute and paying attention to all aspects of the history, physical examination, and the nature of that presentation.
I suppose that the natural question this then leads on to, so our suspicions have been raised with a new presentation. How do we go about investigating the child?
Well, I think that the investigation, if we talk about generally first, then there are a few specifics that I would like to go into. But I think clearly the standard investigations are really important. And I would include dipstick in the urine, because I think the presence of, for example, in a neonate, of significant ketonuria with a metabolic acidosis might suggest an organic acidemia. So it is important to do the routine tests. I think also an important one, perhaps when a child presents with a metabolic acidosis, is remember the anion gap. I won't ask you to tell me what the anion gap is, but
I vaguely remember involved sodium and
tell you that
potassium.
it's the sodium and the potassium minus the chloride and the bicarb. So if you've got an anion gap that's certainly presenting, and people vary as to what they think is significant, but if you're above 20-25, then I think that is significant, and that might suggest again something like an organic acidemia presenting like that way. UNEs, routine urine electrolytes. Don't forget the nice one for picking up a urea cycle defect, really sick neonate, high creatinine, and the urea is virtually zero, might suggest to you a urea cycle defect, and just spotting that one thing is important. Random glucose, creatinine kinase to suggest muscle involvement, your liver enzymes, ALT, AST, creatinine obviously, uric acids, perhaps for uric acid for a glycogen storage disease, metabolic alkalosis may be a clue to a raised ammonia, so look for an alkalosis. Coagulation is important in terms of liver disease and underlying metabolic disorders. And I suppose we've talked about urine for ketones. These days we've got lots of biochemistry, but there might be an odour, and I have seen maple syrup urine disease many years ago picked up from the odour from the urine. So, but don't forget it. But let's not depend upon odours for diagnosis these days.
Sure.
So that's the initial sort of range of investigations. And then I think there's the more specialist investigations. But I suppose that what we're talking about is identifying the potential presentation of an IMD, doing the initial investigations, and then thinking about what are the initial treatment options that we should be doing. I think the key thing is if you're thinking IMD and the child is unwell, then it is important to stop the protein and also stop galactose if you think it could be galactosemia, fructose. So the general rule would be in a sick child who you think might have an underlying IMD is to start 10% glucose plus appropriate electrolytes, and that would involve giving the glucose at an appropriate rate. And I think we should all think about glucose being a prescribed medicine, and we would be thinking certainly around 6 to 8 milligrams per kilo per minute in the neonate, and probably about 6 milligrams per kilo per minute of glucose in the older child, whilst you're awaiting those initial results and thinking about whether this is an inherited metabolic disease. It is important then also to contact your specialist centre, and I would then make sure that you move on to do the more specific investigations, which would include an ammonia, a lactate, plasma amino acids, plasmarase L-carnitine, which should also be done on the dried blood spot card, previously known as the Guthrie card, but to take some L-carnitines. Absolutely key is to take an EDTA sample for DNA, to bank some DNA if you think strongly that this is a metabolic disorder. And those would be the initial things from the blood. And then the other thing is to think of the urine organic acids. And if the child is sick, then it's perfectly acceptable to either just do a quick in and out catheter to get the urine, or if they've got a catheter in place to actually get the urine. So those would be the next range of tests to do, which means you're really then starting to get into certainly contacting your local biochemical laboratory, and also looking to seek advice from a specialist centre. Just the one thing I will add is that as we talk as I'm talking to trainees now who are going to be in practice for many years to come, certainly coming down the line, and not that far off, possibly in April of next year, is the consideration of whole genome sequencing for the sick neonate and the sick child in the paediatric intensive care unit. Now, a lot of those might be inherited metabolic disease. That will be absolutely fantastic in terms of looking at early diagnosis. However, it will be important to recognise that you still need to do the basic biochemistry. For example, what you're suggesting is is around, you would still do the ammonia, for instance, whilst you're waiting for the whole genome sequencing, which may take 4 to 8 days. But that is coming down the line, and I'm sure trainees will be experiencing that over the next few years as that expands, which is quite exciting and interesting.
I had no idea that was even on the horizon.
Yeah, it is likely there'll be a pilot in England, and it may be provided as a clinical service in Wales early next year, but we will see. So look out for that.
Right. Okay. So you've named a whole host of specific tests for me to do there. It'd be really good to, I think, to perhaps talk in a bit more detail about them if that's okay with you. Oh,
so hyperammonemia. Yeah. So I think hyperammonemia is important. Hyperammonemia is can be treated, and we can significantly reduce morbidity and mortality if we recognise hyperammonemia early and institute urgent treatment. Clearly in the neonate, I think one would say that ammonia's up to 100 micromoles per litre, probably within the normal range, and if you have an underlying metabolic condition, it's likely that will be over 200 micromoles per litre. You can see ammonia's raised up to 180 micromoles per litre in the sick neonate, and one has to recognise that. I think after the neonatal period, certainly I think greater than 100 micromoles per litre is abnormal enough to suggest further investigation for an underlying inherited metabolic disease. Ammonias normally would run less than 50, certainly between 50 and 80 micromoles per litre. You might see a metabolic alkalosis, and I think that's important in terms of an early recognition of the ammonia. And don't forget the practicalities of collecting the ammonia sample. It should be a rapid venous sample, which is then put onto ice. You should ring the laboratory before to warn them that the sample is coming, so that they can make sure that their apparatus for measuring ammonia is up and running. And please make sure that the sample is taken rapidly to the laboratory. A sample for ammonia that is left and takes a long while to get to the laboratory could be artificially raised, and I think it's really important that we look at that. If hyperammonemia is recognised, and there are good guidelines on the BIMDG website, and I would emphasise in any emergency situation the BIMDG emergency guidelines, which you can just simply Google, and then you can go on and get further advice, are very helpful in terms of the immediate management. With raised ammonia, I do feel you need specialist advice, because that may include the use of nitrogen scavengers urgently, such as sodium phenylbutyrate, sodium benzoate, and also the possible use of another medication in the form of carbamyl glutamate. Also, should the ammonia be significantly raised, then one would be wishing to look to transfer the child to a specialist centre where hemofiltration can be performed whilst awaiting the outcome of investigations. So I do think hyperammonemia is important to recognise, as we can reduce significant morbidity and mortality. There may be a time, if the ammonia is raised for a long time, that in discussion with the specialist centre that may result in consideration of palliative treatment. But once again, that is a decision taken jointly with a specialist centre. Hypoglycemia is important, and I think the key thing about hypoglycemia for any clinicians such as myself looking after patients with inherited metabolic disease is really to try and make sure that the laboratory glucose is collected at the time of the presentation of the child. Sometimes we know that very effectively our paramedic colleagues will have performed a blood sugar and actually instituted treatment with glucose supplements. Certainly below 2.7 millimoles per litre in the child, and probably below 3 millimoles per litre we would consider further investigation. You can take urine samples for urine organic acids, even following the use of glucose, and it clearly, if there is time, and I understand in most A&E departments now we have a hypoglycemia box where there should be a set protocol for rapidly taking bloods with the available bottles, as this is a complex business and we wish to get on and treat the child for the hypoglycemia. That would include looking for underlying endocrine causes, which would obviously require the measurement of cortisol, also with insulin and C-peptide. And from a metabolic point of view, as I said, urine organic acids can be collected in the next urine sample. We would also wish to look at the plasma acylcarnitines acutely, the plasma amino acids, and also the ammonia. That would also obviously include other routine investigations. Treatment with bolus followed up by infusion of glucose would be important. I think it's important to differentiate between the presentation of hyperinsulinism and possibly underlying metabolic disorders in the neonatal period. Certainly with hyperinsulinism, one will be seeing very high glucose infusions above the normal 6 to 8 milligrams per kilo per minute that we see with the neonate, and the neonate requiring that amount of glucose. That in itself requires special management with good venous access to ensure that the glucose supply is not interrupted whilst you complete your investigations, supported and perhaps in that occasion by the endocrine specialist service and the consideration of further treatment. I think others to mention, one could go into great detail, but clearly lactic acidosis is important, and presentation of underlying mitochondrial disease at birth can appear. I think generally with mitochondrial disease, what we would see is a number of systems involved, and those will be the high energy systems, which would obviously be presentation perhaps with cardiomyopathy, presentation with seizures and encephalopathy and a floppy infant, also perhaps with hepatic and renal problems. Important perhaps for the muscle disease to look at the CK in that presentation, and obviously it would be important to look at the acid-base balance and look at ways of correcting that. Again, the presentation of these disorders does require discussion with either a metabolic specialist, and obviously sometimes that will require the services of paediatric neurology, where there is a cerebral presentation of the mitochondrial disorder. Other specific situations, I think metabolic acidosis with ketosis can suggest an organic acidemia, and investigation for that. Interesting one, I think, that perhaps we see, and you do see not infrequently in the neonatal unit, is the presentation of hydrops fetalis. If they do not have an underlying hematological problem or no obvious cause for the hydrops, and it can be quite mild sometimes or quite severe, then lysosomal storage disorders and some other metabolic disorders are likely to or can present with hydrops fetalis, and perhaps it might arise in a situation where there's been a previous child that might have sadly died from hydrops, and you see a further family presentation. So I think hydrops fetalis does on rare occasions have an underlying metabolic cause. That perhaps leads in then to the important consideration of investigation of neonates or investigation of children who present acutely without a diagnosis, but in whom you think may have a metabolic disorder, and unfortunately do not make it in terms of the initial presentation, and sadly may pass away with the severe disease. The important thing there is to make sure that we do collect the samples that enable us to make a diagnosis, so we can give information to the family and also offer appropriate genetic counselling for further pregnancies. Don't forget that most of the inherited metabolic disease is autosomal recessive, so that family may run a 1 in 4 risk of having a future affected child. It's important to collect urine for the urine organic acids, and if a catheter specimen is needed, then a catheter specimen should be taken. We've highlighted already about investigation, and the key ones for me in this circumstance would be plasma acylcarnitines, collected also onto a blood spot card, or what may be known as a Guthrie card. I think also you can analyse DNA samples from a Guthrie card, but I would suggest other samples are taken for that, and I'll mention that in a minute. I think plasma amino acids would be important, and the routine biochemistry in terms of the anion gap, measuring obviously the ammonia and the liver function, renal function, and a CK would be important. Taking blood for DNA storage is very important, and that once again we can sometimes get that from the blood card, the Guthrie card, neonatal blood spot card, and also collect blood, 5 mils of EDTA, which can just be stored by the genetics service for future analysis. A skin biopsy can be very useful, and you don't need to have the actual genetic storage material for the skin biopsy. There are specific mediums that can be used to store skin, but in the absence of that, it will be very satisfactory to collect a small piece of skin, a small ellipse, under sterile conditions, and that's the key thing, under sterile conditions, and put that ellipse into sterile normal saline and store it in the fridge, not in the freezer, but store it in the fridge, and make sure it is forwarded rapidly to your genetics laboratory, where you would stand every chance of then getting a good skin fibroblast culture from which one could then do further genetic studies, and one could also consider further studies for enzymology. So I think that's those are a number of highlights which I'm giving you from my career, which I think would be useful to trainees. Once again, emphasise that there is advice out there. The British Inherited Metabolic Disease guidelines do provide you with very clear advice around emergency situations whilst awaiting further advice, perhaps from a senior consultant colleague or from the specialist centre.
Yeah. So I think the key messages for me that I've taken away from our teaching today is, first, any suspicion, just do a gas, because acidosis and alkalosis seem to be key findings with these infants. And if in doubt, look up the guidelines. If the parents don't have anything with them, or you can't get hold of anyone immediately, there are readily available guidelines on the internet.
I think that's right, and I think what we're both saying is that clearly in the sick neonate or the sick child, there are many other causes for that child being unwell. However, we can significantly reduce morbidity and mortality if we think of an inherited metabolic disease, and we think of the additional things that we've mentioned: the family history, the possibility of family history, the liver disease with an encephalopathy. Just thinking beyond the usual things that we would start to think of, clearly, which in the main involve the treatment of sepsis and some other more common problems in inherited metabolic disease. But the plea is really to consider inherited metabolic disease, because if you don't think of it, if you don't measure the ammonia, then we will not be making these diagnoses earlier and preventing handicap, which we potentially can do. And in my final point, I think it really is about, if the child's not going to survive, sadly, then it is about trying to make the diagnosis for the family.
Okay. Well, thank you very much for that, Dr. Shortland.
Thank you so much for such an informative podcast, Assim and Dr. Graham Shortland. So just to go over what was talked about. They talked about the importance of taking a history, checking the family history, consanguinity, a history of HELLP syndrome and previous miscarriages, a history of neonatal sepsis-related death or a death of another unknown cause. And in the examination, non-specific findings such as lethargic or poor feeding, and an asymptomatic interval period which changes on feed introduction, evidence of liver disease, hypotonia and seizures. And in the sick child, check the family history. Look for non-specific signs: liver dysfunction, cardiomyopathy, encephalopathy, and repeated admissions with innocent sounding presentations. So in initial investigations, urine dipstick, blood gas, and check for the anion gap, the usinase, glucose, creatinine kinase, liver function test, uric acid, coagulation, and look at the urine odour or smell the urine odour. And then specific investigations, so ammonia, lactate, plasma acetylcarnitines, plasma amino acids, and then bank a sample for DNA, urine organic acids, and soon to come, the whole genome sequencing. They also talked about having a high ammonia, having hypoglycemia or hyperinsulinemia, the features of mitochondrial disease, metabolic acidosis with ketosis, and then the presentation of fetal high drops in the neonate, and investigating the child who dies with the suspected inherited metabolic disease and the importance of taking samples in that situation. Anyway, thank you very much for joining us, and thank you for listening to Dragon Bytes.